Thank you, Mr. Chairman, dear colleagues. There is a great heterogeneity in the world regarding the use of corticosteroids. For example, in this survey, which was done in the UK, 70% of the responders declared to use corticosteroids. And corticosteroids were mainly used during the first 2 weeks. And regarding the molecule, it was in more than 50% of the cases methylprednisolone which was used. In contrast, in Canada, more than 50% of the responders declared never or usually not using corticosteroids in ARDS, and only 20% declared to use sometimes corticosteroids for severe ARDS patients. So, great variety of decisions. Regarding the physiopathologic changes during ARDS, the first week is characterized by edema, as extensively described in previous talks. And there is also a proliferation, cellular proliferation, during the first week, and this proliferation increased during the second week. And there is also fibrosis, which increase and which is very important after 2 weeks. And this is related to a bad outcome. In this study, we showed that in all patients presenting fibrosis, mortality rate was 57%. And this is mainly due to a maladaptive response to the insult, with an excess inflammation, and this inflammation is sustained, with also coagulation disorders and an excessive tissue repair. This is when there is a persistent ARDS. In contrast, in patients with an improvement, there is a decrease in all these parameters. And steroids are able to interfere with this response by decreasing the production of pro-inflammatory cytokines, by also decreasing some other pro-inflammatory factors, by also and mainly inhibiting fibroblast proliferation and collagen deposition. And steroids, finally, are able to decrease neutrophil activation. What about clinical studies in ARDS patients? Regarding the prevention of ARDS, there is no place for corticosteroids, which have proved to be deleterious in these patients. Regarding the treatment of ARDS, 6 randomized controlled trials have been published, and we will detail some of these RCTs. As you can see on this picture, for the first 4 studies, inclusions were done prior to 2003. The first study has been done by Meduri and included 24 patients and 8 control patients and 16 treated by steroids. 3 important points. First, corticosteroids or placebo were given after 6 days of evolution of the ARDS. Second point, there was no recommendation regarding mechanical ventilation management except to maintain plateau pressure lower than 35 centimeters of water. Third point, methylprednisolone was used at 2 milligrams per kilogram during 1 month with a progressive tapering of the dose. Interestingly, there was no information regarding tidal volume. However, you can see here that more than 1/4 of the patients presented a pneumothorax on inclusion, and there were more pneumothoraxes by the end of the study, which suggests that mechanical ventilation was not very protective in this study. The second study done by the ARDS network, the Lazarus study, also was done in patients included after at least 6 days of evolution of ARDS. And methylprednisolone was used at 2 milligrams per kilogram. However, tapering was faster than in the medullary protocol. Regarding mechanical ventilation strategy, high plateau pressure were used. 34 centimeters of water was the mean plateau pressure, and large tidal volume, essentially during the period preceding publication of the results of the ARMA study. High tidal volume were used. There was no difference regarding mortality, but a decrease in the duration of mechanical ventilation. That means an increase in the number of ventilation-free days at day 28 in the group of patients receiving corticosteroids. However, you know that the result of the study that is the most detailed in the meetings is this result with an excess mortality in the subset of patients included after day 14. This excess mortality was observed in the methylprednisolone group. However, you can see that these conclusions were drawn from a sample of only 48 patients. Regarding one of the questions asked by Jean-Louis Vincent, there was no excess in critical illness neuromyopathy in the group of patients receiving corticosteroids. And regarding the risk of infection, this study done by the ARDS network, but also others, showed that there was no increase in infection. On the contrary, there was a decrease in the rate of ventilator-associated pneumonia and in the rate of septic shock in the group of patients receiving steroids. In this postdoc study done by Jilali Annan, the design was slightly different. Corticosteroids were given early in the course of ARDS, during the first week of ARDS, associated with septic shock. And methylprednisolone was replaced by the usual association proposed by Jilali, hydrocortisone and fludrocortisone. 200 milligrams of hydrocortisone is approximately 40 milligrams of methylprednisolone. So a short course of corticosteroids early in the ARDS process. And there was no difference regarding mortality nor duration of mechanical ventilation. There was a slight improvement after adjustment. And interestingly, also in this study, large tidal volume were used. Mean was 9 milliliters per kilogram, associated with low PEEP level. Paolo will be happy. Early corticosteroids were also proposed in a most recent trial done by Meduri, and patients were included during the first 3 days. And the dose was not 2, but 1 milligram per kilogram, and the duration 28 days. There was no guideline regarding mechanical ventilation management, except after the publication of the ARMA study. And the authors showed that there was an improvement regarding the duration of mechanical ventilation, which was reduced in the group of patients receiving steroids. However, there was no difference regarding mortality. There is no information regarding tidal volume and other mechanical ventilation settings. A more recent study used the same design. Patients were included during the first 2 days, 1 milligram per kilogram of methylprednisolone, treatment duration 28 days. However, on only 27 patients, the authors showed an improvement in the outcome related to the use of methylprednisolone. However, there is no information regarding mechanical ventilation strategy. And in this last study, the most recent published study, it was a single center randomized control trial about the same design than in the study done by Jilali Annan, 1 week duration of hydrocortisone early in the course of ARDS associated with sepsis or septic shock, and their patients were ventilated according to a protective ventilation strategy, and there was no effect on mortality, neither regarding mechanical ventilation or duration of hospitalization. Treatment tapering is maybe an important aspect to consider. In this post-hoc analysis of his trials, Meduri showed that for when patients were disconnected from the ventilator after rapid treatment tapering, they finally returned to mechanical ventilation in 26% of the cases. In contrast, when there was a slow treatment tapering, only 8% of these patients returned to assisted breathing, suggesting that the tapering of the treatment is a key factor in the success of corticosteroids. Maybe additional trials are needed because many of these trials were conducted prior to 2003 when lung protective strategy was not implemented. The selection of the patients was only based on PF ratio. There are many discrepancies regarding timing to start steroids, the dose, the duration, and the tapering of the treatment. If we want to study corticosteroids and their effects on mortality, it would require at least 1,000 patients. You see that even for the ARDS network, it took approximately 6 years to complete a study including 180 patients. And on the other way, there are recent advances regarding ARDS management with probably less lung injury and less lung inflammation and maybe less activity of corticosteroids, which is suggested by the last trial. So probably we should start by trials investigating duration of mechanical ventilation or ventilator-free days and maybe long-term effects. Fortunately, there are 2 ongoing studies, one in Spain, investigating the use of corticosteroids very early in the course of ARDS. The main outcome is ventilator-free days. And the second one in France, but there are several differences. It was for persistent ARDS, and patients will be included only if there is an increase in procollagen-free in BAL. Procollagen-free is a marker of fibroproliferation, and it has been shown in a post-hoc analysis of the ARDS network study that there was a beneficial effect of corticosteroids when given only to patients with a high level of procoagulant free. This is my last slide. It is about a recent guidelines produced by the European Society and also by the SCCM. You can see that the experts suggest the use of corticosteroids during the first 2 weeks. It's a conditional recommendation with moderate quality of evidence. This is pictures from my region, and as we said in Corsican language, it was a great pleasure for me, and vi ringrazio di ascoltare mia presentazione. Grazie.